Good afternoon, everybody. Thank you for joining us. My name is Carlita, and I'd like to welcome you to today's Ask the Expert, titled ADHD and Preschoolers, What to Look For and How to Help. Today's webcast is brought to you by CHAD, Children and Adults with Attention Deficit Hyperactivity Disorder. We improve the lives of people affected by ADHD and provide reliable, science-based information about ADHD management. During this webinar, we would love to hear from you. You can type your question in the box and we will answer them at the end of the presentation. If for some reason we're unable to get to your question today, we do have health information specialists that are available Monday through Friday between the hours of 1 and 5 p.m. Eastern Standard Time. You can reach our health information specialist at 1-800-233-4050. I am pleased to introduce today's expert, Dr. Mark Mahone. Dr. Mark Mahone is a child neuropsychologist, vice president of neuropsychology and related services at Kennedy Krieger Institute, and a professor of psychiatry and behavior sciences at Johns Hopkins University School of Medicine. For 25 years, his research and clinical work has emphasized investigations of brain-behavior relationships in children with neurodevelopmental disorders, with particular focus on ADHD. He is also the author of 130 peer-reviewed research publications, 15 book chapters, and is the co-editor of 2008 book, Neuropsychology, Science and Practice, 3rd edition by Oxford University Press. His work has been continuously funded by NIH for 20 years, and his research findings have been featured on NBC Nightly News, NPR All Things Considered, the New York Times, and Washington Post, just to name a few. I am pleased to introduce today's expert, Dr. Mark Mahone. Would you like to begin today's presentation?
Thank you. And I'm going to pull up my slides. Is that right? Perfect. Welcome, everyone, and good afternoon. I am happy to be here again to talk to you about ADHD, and in this case, about ADHD in preschoolers. Okay, one moment. Up. Had a little technical difficulties. I think we're good now. So why do we should we be concerned about ADHD? Well, you probably know because you're here today, but ADHD is the most prevalent psychiatric disorder in children, and it has costs for our society of at least $143 billion a year over and above the costs to typically developing children. And a quarter of those costs are borne by our education system. And that really represents a six-fold increase over students without ADHD. So this is really a public health issue. And ADHD is prevalent, very prevalent, and we do surveys of the US anyway of how many children are diagnosed with ADHD. And the most recent ones by the Centers for Disease Control suggest that in the ages of 4 to 17 years, approximately 10% of children have been diagnosed with ADHD. Now, there are controversies around those numbers, and the worldwide rate ends up being a little bit less than that, which we can discuss a little bit in the question and answer time. But as you can see from this slide presentation, ADHD is more prevalent in boys than girls. And what you see is that the prevalence differs depending on your age range. And so in the preschool years, you'll see that the numbers are much lower, with 4.3% for boys and 1.2% for girls, and about a 3% overall rate. Whereas in the school age years, it's about a 10% rate overall, with boys, again, more than girls. But when you get into the middle and high school years, it's nearly 12%. So this rate seems to increase as you grow older, and the proportion of boys versus girls changes as we grow older as well. And let's hold on to that. I'm going to come back to that issue in just a bit. But ADHD is in fact a major public health issue, and I emphasize health broadly, not just behavioral or mental health, but also learning and other physical conditions as well, including learning difficulties in school, missing school, troublesome relationships, and a whole host of mental and physical conditions which are increased in children with ADHD, who have approximately 7 million ambulatory visits per year. Interestingly, as adults, people diagnosed with ADHD in childhood have 33% reduced earning and 15% increase in social assistance. So again, this is a lifelong problem for many, but it does often start in the preschool years. And even though it may not be diagnosed until later, many of the risks are there in the preschool years. Many of the behaviors are often identifiable in the preschool years. Here's a study I'm referencing here that adults who were identified as hyperactive during their preschool years have 17 times higher annual health care costs. And another, based on a large study of treatment of preschool children with ADHD, suggests that even when effectively treated and carefully treated, they still have functional difficulties by the time they get to elementary school. And that's for people who are treated. Those who are untreated have even greater risks associated with outcomes as they get to elementary school and beyond. And so we're doing a good job with treatment, but in some ways we're not covering all the bases. And I'm going to touch on some of our thoughts about that toward the end. So it's important to remember that while ADHD has been characterized as a psychiatric condition, it is now understood as a neurodevelopmental disorder, meaning it has its onset in early childhood, probably with part of the condition that you're born with, and it develops and unfolds and changes over time. And for many people, the symptoms of it exist throughout the lifetime. Even if the full diagnosis isn't present throughout the lifetime, symptoms are often present throughout the lifetime. It's in most people, it is not a condition in which all the symptoms remit or you grow out of it over time. And so thinking about it as a developmental disorder makes one want to think about the course of the condition. Here are some data from neuroimaging studies. And what it's shown in many neuroimaging studies, looking in this case at cortical thickness or brain development thickness, which is a marker for brain maturity, one can see that in typically developing children that the curve starts to reduce, which indicates pruning in the brain, which indicates a time of maturity in typically developing children around 8 or 9 years. But in children with ADHD, that curve doesn't start to go down for another 3 years later. And one way to think about that is that during the elementary school years, children with ADHD, their brains are still developmentally less mature toward maturity than children without ADHD. And that's critical during the elementary school years. And I'm going to show you data that suggests that that's even true in the preschool years. So another thing to think about is that the brain develops not all at one time, and certain parts of the brain develop earlier than other parts of the brain. And this slide shows you that the frontal parts of the brain, and in particular the prefrontal cortex, are really the last parts of the brain to develop and really continue to develop and myelinate well into the teens and into the second and third decades of life. Whereas other parts of the brain, as you can see, are very active in their development, even in infancy and early childhood. And what that means, though, is that brains don't develop on their own. They develop in the context of the environments in which they live. And so all behavior and all brain function is really a function of genetics at some level, but it's also a function of the interaction between the brains and the environments that people are in. And so those environments that children are in the preschool years and even in infancy are critically important for development, not just with regard to behavior, but with the brain itself. So on this slide, I want to talk to you a little bit more about development. And so most of us think about development as rather linear, meaning that children start to to gain skills in early childhood, and they really grow with those skills very rapidly through the elementary school years. But what we've learned by taking a closer look at how children develop is that in many skills in this particular test, this is a memory test, in many skills that children develop, you really can get to be just about good as you'll ever get, or good enough for life, by about 8 or 9 years old. And that rapid development and learning and acquisition of these skills occurs during those preschool and elementary school years. Now, I'm not talking about academic skills like vocabulary, but more core cognitive skills like memory, for example. Here's another one that shows you that this is a reasoning skill about being able to take the perspective of someone else. That's called theory of mind. That skill plateaus. It starts to plateau about 8 or 9 years old. And another one, being able to recognize affect in other people, skills that are critically important for social development and social interaction. In most people, they get pretty far along by about 8 or 9 years old. And what does that mean? That means that by adolescence, most of the time, many of the skills that are expected to be in place for children in terms of core cognitive skills are expected to be there by 10, 11 years old. Now, remember what I showed you before was that the brains of children with ADHD tend to develop later. And so that means that some of those cognitive skills are also likely to develop later as well in children with ADHD. So that they may not get as good as they're going to get until adolescence, or in some cases early adulthood. So this slide I'm showing you now talks about this idea of the emerging lag, and this is something that parents and teachers worry about quite a bit. And what that means is that if typical development is the dark bar there, and the developmental trajectory of a developmental disorder, for example ADHD, is the lower bar there, you can see that what concerns people is that gap grows over time. Well, that's true if development is always linear. But remember, I told you in the last slides that development isn't linear. And so what we may actually get is a trajectory where normal development plateaus and starts to just stabilize at around 8 or 9 or 10 years old, whereas development in ADHD may continue well into adolescence and even young adulthood if you let it. And so what happens is that while the gap may grow early on, with continued support and continued intervention and given time, that plateau won't happen until much later in life in people with ADHD. And so eventually, with continued support, that gap will be reduced again. And that's why I call it the fallacy of the emerging lag, because if you don't think about the trajectory and the development far out enough, you will just worry about the gap just growing over time. So let's go back and talk about preschoolers for a minute. So those of you probably know that there's been more of an emphasis on early childhood education throughout the United States. And in many states, that takes the form of universal pre-kindergarten or more formal pre-kindergarten settings for many of the 4-year-olds and even younger. And while conceptually that's great, there are fewer trained teachers out there for preschoolers than there are for school-age children. And the skill sets for teachers of preschoolers are very different than the skill sets of teachers of elementary school children. And so what we're looking at is an expansion of early childhood education and extending kindergarten down to 3 and 4 years old. And so you'll see children in classrooms that may not be set up sometimes in developmentally appropriate manners. And because they're in more formal classrooms, some of the behaviors that will catch the eyes of teachers may be interpreted as looking like ADHD, right? And so it's important to remember that many of the behaviors you see in ADHD are not abnormal behaviors. They are normal behaviors at some level, it's only the amount and the frequency of these behaviors that makes them problematic. And so that's sometimes much more difficult to tease out in preschool children. And Steve Hinshaw has written quite a bit about the idea that there are risks associated with looking at children, especially in 3 and 4 and 5-year-olds in pre-K, who are having behaviors that may be developmentally appropriate in the big scheme of appropriate behaviors, but because they are in more formally structured classrooms and having more kinds of academic demands put on them earlier, they may be labeled as having ADHD. And so that's a concern that I think it's important to think about when interacting with preschool teachers. I'm not saying that pre-K isn't a good thing, just the opposite. Pre-K is a terrific thing, and there's lots of evidence to show that pre-K can be a tremendous resource, but it may put more children at risk for being identified as having problem behaviors. And what does that mean? That means that when these children come to the attention of a professional, a pediatrician or a psychologist, that a careful assessment of whether or not these behaviors are within normal range for age or whether they're abnormal needs to be done. And that's not always so easy. So this slide I'm showing you now is one of a number of studies that have been coming out over the last 10 years or so that show a pretty striking common finding. And in this particular study, on the left graph, you will see states that have a September 1 cutoff date for kindergarten. And that means that if you were born in September, you were one of the older for class. If you're born in August, you're one of the younger for class. And so you can see that the highest rates of ADHD diagnosis are for those children born in August, again, the youngest for grade. Then you look on the right, in states in which December 1 is the cutoff date, here the highest rates of ADHD diagnosis are for those that are born in November. Again, in both cases, it's the children who are younger for grades. And it's not only ADHD diagnosis, but as you can see, medication rates and medication use in this age range as well. So there is a risk of identifying children as having abnormal behavior when they are young for grade. Here's another study that was done. This was done actually in Taiwan that showed pretty much the same thing. This is a September 1 cutoff date, and you can see that there's almost a linear effect for how many children are diagnosed with ADHD as you get closer to the August date of birth. But what you can see pretty clearly here is that that's much more the case for boys, which is the top line, than it is for girls, which is the lower line. In fact, there doesn't seem to be much difference at all in month of birth for ADHD rate among girls, where you see it quite a bit in boys. And why is that? Well, boys develop later than girls, and I'll talk about that for a second. But it also means that if you are younger for grade and you're a boy, because boys develop later than girls, then you have a double whammy and a double risk of having your behaviors be identified as ADHD. And so what we want to do is identify correctly people who have ADHD, identify correctly people who don't, and help them accordingly, and also identify people who may have something else, or the ADHD and something else, and I'll get back to that in a moment as well. So back about 6 years ago, the American Academy of Pediatrics put out their more recent guidelines about how to diagnose and treat children with ADHD. And for the first time, they made an effort to really emphasize what the care should be for children in the preschool years who present with symptoms of ADHD. Now, the American Academy of Pediatrics recommended that the first line of treatment should be behavioral before you go to medication. And so those guidelines, as you can see on here, were released in 2012. This are data from insurance companies about claims for behavioral versus medication treatment of preschoolers with ADHD symptoms. And as you can see, there is virtually no change in practice among pediatricians and physicians following the American Academy of Pediatrics guidelines with regard to using medications as the first line of treatment. And as you can see also, the behavioral treatments did not go up. So even though those guidelines are out there and have been published from 2012, they're still less likely to be used. Now, there's also controversy about whether or not simple behavioral treatment alone for childhood ADHD in the preschool years is adequate. And there are a number of researchers who would suggest that it may not be adequate, and that eventually, if it really is ADHD, then one would likely have to add medication as well, or a combination of medicine and behavioral treatments at the same time. But suffice it to say that many children out there are receiving medication, but not necessarily behavioral treatments. So getting back to boys and girls, do you remember I said that boys develop later than girls? And if you talk to any kindergarten teacher, they'll say, of course, we see that every day. Because when children get to the kindergarten years, you can really see a difference between boys and girls. It's even noted at birth that girls can be as much as 3 weeks ahead of boys in their physical maturation, and a year ahead of boys by the time they get to school. And that maturation comes not just in physical development, but also in cognitive development in many areas, language, motor skills, and importantly, social emotional skills as well. Girls' brains develop earlier than boys, and especially the parts of the brain that are important for behavioral regulation, and that's in particular the frontal lobes. And here you can see normal development among boys and girls, and that point at brain development that seems to be where it plateaus and starts to be reduced is thought about as different parts of the brain when those parts of the brain mature. And you can see in virtually all parts of the brain in normal development, boys' brains are bigger, but girls develop earlier, girls mature earlier. And so that also leads us to think about, well, we need to think about what ADHD looks like in the preschool years, and how is that different than what it looks like in the school age years. But it's also critically important to think about how it presents differently in boys and girls. Here's a very interesting finding that has been published over the last few years, not just in ADHD, but in other developmental disorders as well. And what it is called the female protective effect. And you remember earlier I noted the statistics that boys get diagnosed with ADHD more than girls. But when these studies, and this particular one I'm showing you now, these 3 different graphs, these are 3 different cohorts, 3 different studies that each showed the same thing, is that when you look at twins, twins with ADHD, one of whom is a male or one of whom is a female, and if the twin with ADHD is a female, then the co-twin is much more likely to have ADHD symptoms. And that's a little bit complicated, but really what that means is that if you are a female and you develop and manifest the condition of ADHD, that you actually break through and have symptoms of ADHD enough to have a diagnosis, that you are likely to have a higher genetic load for the condition than the boy would. And we do see that, especially in the younger years, in brain development as well, and I'm going to show you that. So again, females have biologically are protected against this condition, in part because they develop earlier in life, but when they actually do develop the condition, genetically they may have a more severe phenotype or genotype than boys. I want to show you some evidence from our studies from the past few years, and then get back to some of our evidence from preschoolers. But this is just an example of children. This is about 140 children with ADHD, boys versus girls. And what we looked at is abnormal motor signs. Motor development often occurs with more difficulty in children with ADHD than in children without. And what we see are atypical kinds of motor signs on motor examination that continue well into adolescence for boys with ADHD. But in this study, we showed that they seem to go away in girls with ADHD much earlier on in life, by about 9 or 10. And so it's another example of how, not only in terms of brain development, but also in terms of behavioral development, girls mature earlier. And it made us think about, well, what, if this is a developmental disorder, and we know that there's something about girls that protects them from the disorder, well, what can we learn from that? And so that made us think, well, maybe we just need to study this disorder earlier in life. So about 10 years ago, my colleagues and I started studying the brains of children in the preschool years who present with ADHD. And you might think, wow, how do you do that? It's a little bit hard to get a child who's hyperactive that's 4 years old to lie still in an MRI scanner, and that's absolutely true. And so we have a great team of colleagues here, of behavioral psychologists who are really good at working with children to get them to lie still in a scanner. We don't use sedation or anything like that, and we've been quite successful in doing that. And so we've now scanned several hundred children over the last few years with and without ADHD, starting in the preschool years. And we initially found right off the bat that in this particular study that the caudate nucleus, which is the subcortical region of the brain, is smaller in those 4 and 5-year-olds with ADHD. And the rate with which it's smaller, the smaller it is, the higher or the more likely you are to have hyperactive symptoms. We also looked at total brain volume, and interestingly enough, what we saw was that in total brain volume, the size of your brain, that girls had a much more severe reduction. Girls with ADHD had a much more severe reduction than boys did, even though both genders had reduced brain size by the time they were 4 years old. And these are children carefully diagnosed with ADHD by 4 or 5. We also showed that subcortical parts of the brain, in particular the caudate nucleus and the thalamus, also were reduced in children with ADHD. Again, in these 4 and 5-year-olds, it's mostly in the girls rather than in the boys. I can tell you that you can see those bars on the right, that in samples of children who are school age, those findings are very different, and that boys look more abnormal than girls. So we've been looking at brain development in preschool children who present with ADHD. And sure enough, we found that if you follow them from 4 years old all the way up until they're in elementary school, till they're about 7 years old, we follow their brain development. And as you can see by the number of scans that we've taken, their total brain volume is continuously smaller in children with ADHD, even by the age of 4. And that gap grows by the time you get to age 7, suggesting that even by age 4, brain development is happening more slowly in children with ADHD than without. Again, we looked at this in boys and girls, and here again we found that brain development gap was much more pronounced, much bigger in girls with ADHD than it was in boys. Even to the fact where if you're a girl with ADHD, your brain development starts to plateau by the time you're about 6 years old, which is a new finding that is really surprising to us. We expected we'd see that in boys as well, but much more so in girls. So just to summarize what we've learned about brain development is that by 4 years old, children who are carefully diagnosed with ADHD and carefully assessed to present with ADHD have markedly reduced size of their brain relative to age-matched children without ADHD. It's not attributable to medication because none of these children were on medication when we started to follow them. And that in girls, we see a pattern that's much more unusual or atypical than we see in boys, which is just the opposite of what we see in school-age children. So this, thinking about ADHD as a developmental disorder we now think of this early preschool years as very much a sensitive period, very much a period where there's rapid growth, rapid change, and at the same time, rapid or really high likelihood that interventions and the environment are likely to have a major impact on your brain development during that period. So here's a study we looked at in motor development, and just one example of what a sensitive period means and why we need to think about this as a developmental disorder. So again, we looked at motor examinations and to see what kinds of motor difficulties are sensitive in distinguishing children with ADHD from those without at different ages. And one task we had was a simple finger tapping task where you tap the index finger to your thumb. Very, very easy for preschool children to do. And the speed with which you do that, as you can see on the left graph, at 4 years old is a very, very sensitive indicator of whether you have ADHD. But at age 5, it's not. But a different task, walking on your heels and walking heel to toe, is a very sensitive indicator when you're 5 years old, but not when you're 4 years old. So what that means is that when we look to see what kinds of things help us know if someone has ADHD at different ages, the test that is sensitive at age 4 may not be sensitive at age 5, and vice versa. So we're learning more about how to think about and use sensitive periods. We also know, and I keep coming back to motor functioning, because as a neuropsychologist, I like to think about how we assess behavior and how it relates to brain function. And motor function is one of the behaviors that we can measure very reliably, and that it has very high association with differences that can be detected in brain function. Here we see that development of motor skills seems to change at the same rate as the improvement in attentional skills in children. So if we know that if we're looking for your attentional skills to improve over time, one way to look at that is to also look at motor skills, because they are likely to have a very similar trajectory of improvement over time. And vice versa, if you see someone in the young age range that has attention problems, you should also very much look for motor difficulties as well, because they do seem to track together. And if you miss parts of the overall picture, you're more likely to have incomplete and often ineffective treatment. So all of this background knowledge has led us to think about, well, what do we do with this now? What do we do with this new knowledge that we've gained from our work and from others to really intervene in a more thoughtful and long-lasting way in young children, preschoolers, who might present with things that look like ADHD? And so we've been talking for a number of years about building better brains. And the reason we are talking about that is that we've found, and in my line of work, we've found lots of things that we now know are not good for brain development. And none of these things would be surprising to anyone. So things that are not good for brain development are not getting enough sleep, not getting good nutrition, not having enough exercise, having a stressful environment, and toxic and chronic stress is bad for brain development as well. And also the interaction between how schoolwork and learning is introduced to children absolutely affects their brain development. So more exposure to wide ranges of learning opportunities in multiple contexts is much, much better for brain development than simply teaching reading by only drilling and killing. We now know that. We also know that physical development and brain development are highly connected, such that physical health and physical activity actually makes one more ready and more able to pay attention in the classroom, so that the information that is presented gets into the brain and sticks better. So we've been focusing on all of these things as more of a public health approach to thinking about how we build better brains for all children, but in particular children who have neurodevelopmental disorders, and in ADHD in particular, they may be even more vulnerable to not getting these things in adequate amounts. And one of the things I'm going to talk a little bit about right now is sleep. And those of you who have known preschool children that might have ADHD, or preschool children in general, know that napping and sleeping and getting on a regular schedule is critical to their development, critical to their mood and behavior in school, and that, like adults, preschool children who don't get adequate sleep don't pay attention. Just like when I don't get adequate sleep, I don't pay attention as well. So it's even more pronounced in the preschool years. So we set up this study a few years ago to test that out. And so what we did was that we looked at preschoolers, 3 to 5 years old, and we looked at their napping during the day, and we looked at their sleeping at night. And we did that using parent logs and sleep logs, but we also used actigraphy as well. They actually wore a version of an Apple Watch, and it monitored how much they actually slept, both during nap times and in sleeping. And we did that over a week. And what we thought we would find is that those who napped less during their preschool or their pre-K would have more problems with attention and behavior in the classroom. Here's what we did find. Those who napped less during the day actually did better with their paying attention and their behavior in the classroom. But at the same time, those who napped less during the day slept more at night. So there's a strong relationship, not surprisingly, between how much you nap during the day and how much you sleep at night. And those that napped less were actually having longer periods of consolidated sleep at night. And those long periods of consolidated sleep, when children can get into longer periods of slow wave sleep, are really, really, really critical for brain development, and is that seems to be the better predictor in children of when you or how well you do with regard to paying attention and your behavior in the preschool years. In ADHD, we also looked at the relationship between ADHD symptoms and sleep problems. Not surprising at all that we also found that preschool children who had ADHD symptoms were also more likely to have sleep problems or parent-reported sleep problems, and that there was a real strong association between the two, such that more sleep problems led to more ADHD symptoms, or vice versa. We really don't know which is causal. We just know that they go together, meaning that children with ADHD biologically can be more susceptible to sleep problems, or that the sleep problems that they come by may make their ADHD symptoms worse. It could be both, and that's a fruitful area for us to continue to research. So when we think about who has ADHD, I've been talking about all these children in the preschool years that have ADHD. I want to emphasize that diagnosing ADHD in the preschool years is not easy, it's not simple, and it's not something that one does just with a brief 10 or 15 minute evaluation. Part of the reason for that is this slide right here, is that most of the time people with ADHD don't just have ADHD by itself, they have something else. By the time they get to school age, that something else can be things like learning disabilities or conduct or behavior problems, anxiety or depression, speech and language problems, movement disorders like tic disorders, autism spectrum co-occurs often as well. And so if you are only assessing for the ADHD and not looking for those other things, then you're very likely to miss a big part of what's going on with the whole child. And that can't be done in a 10 or 15 minute screening visit. You might be able to say, yes, this child looks like he or she has ADHD symptoms, but you're really not going to get to the bottom of what it really might be, including that the child might be young for grade or have other situational stress that may produce these kinds of things. And so a more comprehensive assessment is really needed. I also say that because the treatment for a primary oppositional defiant or conduct problem and the treatment for ADHD in the absence of those conduct problems are very different, right? So medication helps with ADHD symptoms. Medication doesn't help a whole heck of a lot for oppositional defiant or conduct problems. At the same time, behavioral therapy is probably the best route to go for oppositional defiant behaviors in the preschool years, whereas behavior therapy alone for the core symptoms of ADHD, in particular the inattention part, is less likely to be independently effective without medication if they're only treating that part of the condition itself. So the behavior therapy is much more effective when you have conduct or behavior problems. And so it's really critical for professionals to be able to tease that out, and it's not always easy. Here are some of the things that we might look for, that I tell parents and teachers to look for in 3 or 4-year-olds. And some of these are just an issue of amount or frequency or intensity, because all of these are not necessarily abnormal behaviors in and of themselves. And so children who really dislike doing anything that requires paying attention for more than about a minute can be a sign. That they often lose interest and start doing something else, engaging in another play activity after only a few seconds, that they have a hard time sustaining independent play even if they like something, that they talk a lot more, make a lot more noise than other children. Remember the motor examination I talked about? We found that children who are not able to hop on one foot at least once by 4 years old, that's a risk factor. That is often something that predicts hyperactivity symptoms later on in childhood. And children who are almost always restless, that often get into dangerous situations because of fearlessness, including climbing up on top of things, going up to strangers too closely, often being aggressive with playmates. And one of the key signs that we look for are the children in the preschool years who have ADHD often get injured. And most of those times it's getting stitches or bumping themselves. And if you watch them for a little bit, you'll see because they're moving so fast and their bodies aren't able to keep up with the level of energy and movement, and their motor skills aren't developed well enough to stop them from moving so fast without falling. And so you see children often have a higher in the preschool years have a higher rate of being injured. And these are ones that are in and of themselves. One alone doesn't mean a child has ADHD, but it means that it's something you might want to look for, and that if you see a number of those things, you may want to go to the pediatrician or a child development specialist to have this looked at a little more closely. And so some things that we're continuing to ask is in learning about ADHD, given that we know it's a developmental condition that already rears its head by age 4, is 4 years old even too late? And should we start studying it earlier? We want to know how this early development and improvement in the brain that we see by adolescence can help improve and facilitate behavior. And we want to continue to learn from girls because girls have a more normalization of their behavior by school age years, even when in preschool years it's not that way. So what can we learn about the changes that happen between preschool and school age years in girls that lead to more stabilization and normalization of some of these behaviors? And so I'm going to stop here and take questions and acknowledge some of the grants and my tremendous team of co-investigators and research staff here at Kennedy Krieger Institute. And so I'll turn it over to questions then.
Thank you, Doctor, for your presentation. Just a reminder to our participants, you are able to submit your questions in the section below. We're going to go ahead and jump right into questions. There has been several I saw that came aboard. We'll begin momentarily.
Okay.
Okay, and so we have a question. Is it possible for too much sleep to impact ADHD symptoms? For example, let's say getting 12 hours a stretch at a time for a child who is prone to be hyperactive.
That's a really good question. And again, I would want to know what the age is of the child. And the American Academy of Pediatrics has pretty clear guidelines that you can get online or from your pediatrician about what's an appropriate amount of or range of sleep for young children. And so 12 hours in very, very young children may not be atypical or abnormal. And I should also say that some children with ADHD, when they really wear themselves out during the day by being very active, they will sleep that much at night. And I can't emphasize enough that good consolidated nighttime sleep is really critical for brain development. Good interrupted sleep, such that you get into what I refer to as slow wave sleep. That slow wave sleep is restorative for your brain. It allows memories to be consolidated. It allows a cleansing of certain aspects of the brain through its neurotransmitters. And so it's really critical. I don't want to say 12 hours is too much, but in some ages, especially very young children, that may not be atypical. But I would refer back to the AAP guidelines on that.
Great. And so here is another question. It says, how can we measure stress in a child, particularly in the classroom?
That's another great question because it is true that people of all ages experience stress from infancy all the way up through older adulthood. And it's also true that they may show you how they experience stress in different ways. Children in the preschool years may show it to you via their behavior. And no two children are going to do it exactly the same. Some children may show you that they are experiencing stress by overactivity. Some children may show you that they're experiencing stress by withdrawal. Some may do it with aggression. And so there are a variety of different ways that children can show you. But importantly, some of the symptoms that go along with things like ADHD or oppositional defiant disorder or conduct disorder or other anxiety, those symptoms can look exactly the same as symptoms that are associated with stress. And so it's important that the evaluator look at the situation, and we think in child development, we think about the child and we think about the environment, and we think about a match between the child and the environment in terms of the developmental demands of the environment and the supports that are available and to some extent individualized to the child. And so those supports and the demands should be targeted to the child's developmental level and age. And when there are mismatches, when children are asked to do things that are developmentally inappropriate, you will see stress and you will see behaviors. And that sometimes is seen when children are asked to do academic tasks before their brains are really ready to do it. And that's been some concern that's been raised by professionals when they see that the academic expectations of children have gone from first grade to kindergarten to pre-K and are even younger. And so, there's a reason that that school starts in first grade when you're 6 years old, is because the brains are ready to do certain things. When the brains are pushed to do things that they're not ready to do yet, often those little brains push back, and they do that by showing you stress.
Our next question, we have a few more minutes and we can take probably another 2 or 3 more questions. The next question states, it seems as though the presentation was really focused on a combined presentation of ADHD. Can you speak a little more about inattentive ADHD in preschoolers?
I can. One of the things I should have noted is that there are the 2 core symptoms of ADHD surround inattention and those that involve hyperactivity and impulsivity. And as a developmental disorder, those symptoms evolve and change over time. And generally speaking, that younger children show the hyperactivity and the impulsivity earlier in life, and it seems to ebb and then eventually reduce by the time you hit adolescence. Whereas the inattention may not be as prominent in the preschool years in most children with ADHD, but becomes more prominent through toward the end of elementary school and in through middle school and beyond, such that once you pass adolescence, that often the inattention is the more prominent. And so I think it's a bit of a misnomer to think about types of ADHD, because the proportion of inattention versus hyperactivity in any individual can be different and can change over time. What we see and what we've seen in my studies of preschoolers is that the majority of children who come in and get diagnosed have some aspect of hyperactivity and impulsivity. That we infrequently find children in the four-year-old-ish range who have inattention but not the hyperactivity. It does happen. It's much less frequent. And when we do see that, we would be very careful to look for other things that may mimic that in that age range, which could be a language disorder, it could be anxiety, but it does. Now, the other thing that we see is that girls tend to have a higher proportion of inattention relative to hyperactivity than the boys do, but not so much in the preschool years. So the more common presentation in the preschool years is much more hyperactivity, even among girls, but you do see the inattentive type, and we see it so infrequently that it would really be thought of as perhaps a unique aspect of the condition that we would want to study more. But again, before we would come to that conclusion, we would want to make sure it's not something else.
Okay, here is a question that has two parts. The question states, what verbal cues can you provide to parents to get children to externalize what they're feeling? It seems as though we're having a hard time in this area. And additionally, we'd like to find out more information or additional resources for behavior therapy.
Good question. So one, how do you get, and again, I'm going to assume that they're asking about this in a preschooler, right? So I think how do you get a preschooler to verbalize what he or she is feeling? Well, that's in some aspects of what you're asking is a challenge for preschoolers, because they may not always have the ability to independently put words to those feelings or be able to label those feelings. And that's something that they are actively learning during these years. So it is good to give them words, give them simple words that they can use. I'm angry, I'm frustrated, I'm worried, I'm scared. All of those are okay emotions to have, but what needs to come with that, and what's critically important, is the idea that emotions can be separated from behavior. Meaning that if I'm angry, it doesn't mean that I have to hit. If I'm scared, it doesn't mean that something bad is going to happen. If I am frustrated, it doesn't mean that things are always going to be this way. And so I think there needs to be words to put to things, and that does help children, whether it's putting words on feelings or putting words on anything. The more they are able to use words to communicate their inner feelings, the less likely they are to have to use behaviors to do that. But again, with that also needs to come the teaching of the separation between feelings and behavior, especially one around I can be angry, but I don't need to hit someone or be aggressive to someone. But during these years, it's very important to know that this is something that is still very much emerging in these children, and so it's something that can be taught to them during this time. It's not something that they should be expected to know how to do independently already. The second piece is, where do you find resources? And there are a number of resources, not the least of which are on the National Resource Center in terms of where to go to learn about behavioral therapy. I am lucky to be in a setting where we have quite a large number of very, very talented behavioral therapists and have access to those. But I readily recognize that in some places there is less access to behavioral therapists. I certainly think that through your local psychological society or through organizations like the Association for Behavior Analysis or the Association of Cognitive Behavioral Therapy, all of those organizations online have resources about where practitioners are in your state or in your area. But I do recognize that having available a really talented and expert behavioral therapist to work with young children is critically important, but there may be some places where it's harder to access those folks.
And this will be our last question for today. This participant is working in a public school setting and would like to know if you could share with us the difference between a diagnosis, a school-based diagnosis of ADHD, and a clinical diagnosis.
Well, that's a bit of a complicated question, and from my perspective, the diagnosis is the same, regardless of who is making it. Now, because it's based on the same criteria. Now, what it may be referring to is when the problems are primarily in the school rather than outside of the school. Is that still ADHD? Or and if the problems are in one setting but not in others, it's probably not ADHD, and it actually wouldn't fulfill the diagnostic criteria for ADHD, which suggests that the problems have to be present in more than one setting. But you also might be referring to how the diagnosis can be used for things like special education services or a 504 plan in the school. And ADHD can be used if there is a learning problem going along with it in the school system as a disabling condition under the IDEA under the other health impaired category, and that usually has to be diagnosed by a licensed professional outside of the school setting. It also can be, if diagnosed outside of special education or an IEP process, children can also get a 504 plan, which is through the Americans with Disabilities Act, and allows for certain accommodations in the classroom, but less likely to involve direct services. And those accommodations could be things like extra time on tests, or taking a test, or taking certain work in a quiet setting, and so those kinds of accommodations. The difference being that IEPs or special education can also involve direct service in the school setting if it's deemed so on the individual education plan.
Well, that is all the time that we have for today's webinar. I'd like to thank you, Dr. Mahone, for a wonderful presentation. Thank you to the participants for joining us today. If you enjoyed today's webinar, you can see the webcast and others just like it on our YouTube channel. That's Help the number 4 ADHD. Again, thank you for joining us today. This concludes today's webcast.